Let me notice the down. Okay, so good afternoon, everyone. I know we are all excited to hear my lecture about delirium, so thank you for the enthusiasm. Okay, let's get started. We have a lot to cover for this important topic, so we want to make sure that we touch everything, every possible topic that is important. This is what we're going to talk about. A little bit about the incidence and the morbidity attached to this particular diagnosis. How do we recognize and diagnose? What is the neuropathophysiology behind delirium? What are some of the predisposing factors? And of course, the most important, how do we evaluate, how do we manage, and what can we do to prevent this from happening in the first place? Okay, so before we get to the next slide, I know we have some interns, but we also have some second years and one third year, 2 third years. So we have a good mixture of trainees here. And you all have worked in the Hackensack system at least for 2 weeks. That's the minimum, right? All of us have worked at least for 2 weeks. So we've looked at EPIC in the inpatient environment for at least for last 2 weeks. And I'm sure all of us here have seen a patient who is 65 and above. Is there anybody in this room who hasn't seen a patient who is 65 and above at all in our EPIC environment in the inpatient? Okay, great. So what have you, or what do you know about what are some of the processes that are in place here at Hackensack to help us manage delirium? And when I say manage delirium, I mean all the 3 things that we're talking at the bottom of this slide: the prevention, the evaluation, and the management. Are there any systems in place?
I believe there's a protocol that the nurses go through. I think referring to the time, and there's like a whiteboard. I think information being on whiteboard available to the patient. I'm not sure the checklist says that there's always a note in there that says that these things have been done to as sort of prophylaxis against delirium.
So we have our nurses who have been educated about a delirium prevention and management plan, and they do document that in their nursing notes and on the whiteboards. Okay, that's definitely one important step. Because we know nurses are our big help in managing our patient, right? We're there only for 15 to 20 minutes. In the patient room, the nurses are with our patient for 8 hours. What else? So that was a good place. And do you know where, besides the whiteboard, do you know where else to find that information? Okay. And we're going to talk a little bit about that. Okay. Any other processes that are in place at Hackensack to help us? You can definitely volunteer, since you just heard this lecture this morning with our Jerry.
They have a program called the Health Program.
Yes.
And certain floors that are high risk for delirium already have it in place, and it would be at the top bar of your,
it's the banner.
Yeah,
That's
banner
what the
say
EPIC
help.
lingo calls it.
Right. If it doesn't say help patient, then you can always order for it. And you can order help, and it's basically like volunteers who are trained to do certain activities with the patient, like read the news or go over activities that they've been trained. They have booklets for, or entertain and reorient them so that they're not, alone and delirious from the hospital.
So what Wilma is talking about is the health model of care for prevention of delirium, which is used internationally as a delirium prevention model. It is a volunteer-based program that has been here at Hackensack since 2008. And the inclusion criteria for help is any patient who's 70 and above who is admitted to the hospital, so for whatever reason, okay? No specific diagnosis. It's the age specific. And the other inclusion criteria are that the patient should be able to communicate, because it is a communication program, and be able to follow the commands. So majority of the times, English-speaking patients, if we have volunteers who are Spanish-speaking or other languages, we do try to enroll the patient population as well. But those are the big 3 criteria: age 70 and above, able to participate in conversations, and admitted to the hospital. So the 6 units that, or 7 units that the health program is currently active on is 4 St. John, 4 South, 4 North, 4 PW, 3 PW, and 3 PE. And these are our heart failure unit, this is our ortho unit, this is our trauma step down unit, this is a pulmonary step down unit, and this is our ACE unit, which is 4 St. John. Because that's where you're going to maximally see delirium risk factors, and we're going to go through that a little bit. Okay, what else is available to you to help you manage? So if you see that banner, help patient, and it literally says help patient, so it's not complicated at all. You know that your patient has already been enrolled in delirium prevention process. If you're on any other floors, and if you identify your patient as a high risk for getting delirium, and we're going to again talk about it a little bit later, you can always, and that's what we were talking about, you can always request a help consult, a help initiation process through nursing by putting a help order in the computer. Okay. What are some of the other factors which you all should be looking at? Every single patient who is 65 and above, when you're doing your admissions, to know whether, and do you want to answer? Do you know what the, yeah?
Oh, was it like making sure the patient has bowel movement?
So when we're talking about what is already being done, what is already in the system, so as soon as you open the chart, when you're doing your admission, you should be looking at this information that is available to you because your nurses are doing these assessments. Okay, so Hackensack, anybody who is admitted who is 65 and above, all the nurses perform a mini-cog, which is a cognitive screen, and a CAM, which is the delirium screen, on every single patient, and it is readily available in the flow sheet. So all you have to do is click on the flow sheet, on the right upper hand corner, type in CAM, and it pulls in mini-cog and CAM information simultaneously on that screen for you to know. So right in the beginning, you know whether your patient has cognitive concerns and whether this patient was screened negative or positive for delirium upon admission. So all this information is already available to you. You're not doing anything additional to take care of your patient. So please make sure that you access all this information that you've taken so much pain to make sure that all our patients get screened for. Okay, and then on certain floors, we are in the process of, or we've already started a pilot about the delirium prevention bundle, which is again preventive measures offered by nursing staff on that unit, which target specific activities for these patients. And currently 4 St. John is the unit that we target, and we are piloting it. And the goal is that if the pilot is successful, to have this delirium prevention bundle throughout the hospital. Okay, so there's a lot going on about delirium already at Hackensack. And there's a reason why we are addressing this disease so aggressively. Another important factor that Hackensack has done is we are the first hospital in the country to start disease-specific certification through Joint Commission in delirium. Okay. I don't know if you guys know what Joint Commission disease-specific certification is, but this is a standard that is measured by Joint Commission, which is a national agency who comes to your hospital, does survey about your processes, and then you are required to submit your data on a 6-monthly basis to this organization who tracks your records very carefully and helps you get certified or takes away your recognition depending on how you're performing on that particular disease. So Hackensack decided to create its own delirium disease-specific certification in 2011, and we're very proud of that. Okay, so let's start with about what do our patients feel when they are delirious. So there's these are some of the surveys those were done to the patients to understand the patient's perspective of what delirium looks like to them. So one patient described his or her experience as delirium is this: like there's a lot going on, and we're not really sure what this is going on, what's happening, what is the clear picture here. This was the description by one more patient. They felt like they were in the middle of the ocean and they had no way to get to where they wanted to go. and it was a very scary, isolated incident during that particular delirium process. So the reason why we want to understand the patient's perspective better is it's very scary to them as well. So it's not only important for us, but it's equally important from the patient perspective. Okay. Rachel, would I be able to? I should be. Okay, so we're going to watch a quick YouTube video on delirium. I don't know if you guys have looked at some of these videos and on some other diseases, but I really liked their delirium video, so we thought we would start out there. It is quite. If not, I would highly recommend that you go and watch this video. We'll give it
the slides afterwards.
yeah, give it another minute otherwise. Please take a minute. It's literally 5 minutes video, but it's very well done. It's an animated video, and it gives you a good quick review of the delirium. Okay, so these are some of the things that we call delirium as, and the reason being that we are all different providers. We all have all different specialties, subspecialties that we come to our patient with, so we tend to pick what is close to our specialty. So we being in medicine, we tend to use acute confusional status or acute mental status change as a more common go-to diagnosis. But just remember that when you're using this diagnosis, you are talking about delirium. So you need to start having the checklist in your mind when you're seeing these patients. And of course, if you're a neurologist, you're going to call it toxic or metabolic encephalopathy. CMS calls it also toxic or metabolic encephalopathy. And you'll see delirium is not really mentioned as a diagnosis anywhere. But at the end of the day, it is delirium that we're dealing with. Okay, so we're going to start with a case. Okay. We have a 90-year-old female with history of heart failure, hypertension, diabetes, who's brought to the emergency department by family because patient has been having lethargy for the last few days. She does live by herself. Her family, they think that the patient has been lethargic for 2 days, and things are starting to get progressively worse. So, what would you like to know more about this patient?
When was the last time you checked your blood sugar?
Okay, so when was the last time you checked your blood sugar? Important question. Okay, especially knowing that she's diabetic. And what are you worried about? Hypoglycemia as well as hyper. So in geriatric patients, even hyperglycemia can present as lethargy. So you want to know whether it's hypo or hyper. Okay, what else?
Like a baseline understanding.
So we want to know what her baseline cognitive status is, especially since she's living alone. We want to know a little bit more about that. Absolutely. Okay, so I'm telling you, this is a alert, awake, oriented times 3 patient who is able to take care of her ADS and IADS independently. Okay. What? Okay, so you want to know if there's any fever, okay, or any other infection-related symptoms, right? Cough, fever, dysuria, nausea, vomiting, diarrhea, any of the above. We want to know if there's an infectious process going on. Absolutely. What else?
Any change in oral intake?
So you want to know if this patient is dehydrated, is it she eating or drinking enough? So you want to know what the oral intake is. Absolutely. Yep.
Recent medication changes.
Okay. So important, any recent, and when we're talking about recent medication changes, not just the prescription, but also over the counter. So don't forget to ask over the counter medication history as well. Okay. What else? Okay. Any diarrhea? Okay. Anything else? Trauma or fall? Absolutely. So any history of fall is very important to know in delirium patients because it can be a symptom or it can be the causative factor, either or. So you want to know if there's a trauma or there's a fall. Okay. What else? Okay. So we have a diagnosis of heart failure. We want to know if there are any other, besides the weight gain or weight loss, We also want to know if there are any other symptoms suggestive of decompensated heart failure, right? So we want to know about that. Okay. Anything else we want to know?
Any like neurological focal
Okay. So are there any other signs, symptoms that we should be worried about since it's a mental status change? Or is there weakness? Is there facial droop? Any other processes going on?
Any change in bowel, bladder movements, and the blood.
Okay, so any blood in the urine, any blood in the stool, because this is all our differential diagnosis. We want to cover all our systems as we start with the diagnosis of altered mental status. And if we categorize it according to the system, especially with the medical history in mind, it helps you come to the possible differential diagnosis much quicker. And we definitely want to do all that. Okay, so let me give you some information about this patient. So she really hasn't been eating, drinking for a day. Not sure about the fever because family checks on her, but they're really not physically there. And the patient is not able to tell you whether she's had fever. No other specific symptoms. She's not really complaining of any shortness of breath. There's really no cough. Let's see if there was anything else that I had put it on. There has been some complaint of burning in the urine for a day before. And we really don't know what the blood sugar was because patient really hasn't checked it for the last 2 days and family hasn't been able to come and see the patient. So what assessments are we going to do on this particular patient? We've gotten some history. There's really no new medication added to this patient. Patient does take her medications. Besides, there's no fall, no diarrhea as far as the family knows. The patient is not really able to give you much story. She does seem to be quite lethargic when you're interviewing this patient. So what do we want to do next? Abdominal exam? Okay. So before we want to go to the electrolytes, we want to know what are the vital signs, right? That's your deciding factor. Let's see if this patient is really septic, is this patient really hypoxic, what system are we going to target? And then, of course, a good physical exam to figure out what's going on, and then some basic labs. So you would want a CBC, you would want a chemistry. Since there's a question of dysuria, you definitely want a UA. You may, depending on what your physical exam finds, you may want to get a BNP or what other things that are going on in the background. And of course, you want the finger stick as part of your vitals to decide whether this is hypo or hyperglycemia. So we are dealing with, would we call this an acute change in mental status? Okay. So what is the definition of acute when we are looking at delirium as a specific diagnosis? What are we looking at? Okay. So few days. Okay. So and that's the reason I'm asking this question is because we have a very each one of us has a different idea of what acute means. So typically for some people, the acute may mean just last few hours. But in delirium diagnosis, when you're saying acute, in last 6 to 7 days, if that's considered as acute enough to consider in that definition of acute. So we are dealing with delirium here, right? And then we're trying to figure out what is causing the delirium. Okay. So this is how often we should be seeing delirium in these settings. So in ICU setting, almost 70% of the individuals have delirium. In hospice setting, similar percentages. So how many of you have done your ICU rotation so far? Okay. How many of you put the diagnosis of delirium or have seen delirium in head? So do you see that often? Do you see it 70% of the times as a problem list on your patients in ICU? Great. And have you looked at the ICU cam, which I know is done in ICU by the nurses? Have you had a chance to look at the ICU cam? Okay. So next time you're in the ICU rotation, please make sure that you're looking at that ICU cam and addressing it in the rounds with your attending as well as with your nurses. So doing an assessment and not having a plan attached to it is useless, right? Okay. So this is why we target our older patients for delirium management. That one third of our patients, by the time they come to us, are already delirious. If you're taking care of your hip fracture patients, almost 50% of them are going to be delirious. Same thing with surgical intensive units and surgical floors as well. So incidence of delirium is, when you look at the literature, is quite high. But when we do a day-to-day practice, we don't necessarily see that often. Is that the right statement or is that the wrong statement? From your short experience, from 2 weeks to 1 year, or 2 years or 3 years, would you say that you diagnose delirium in those many of your geriatric population? Or is it not? And these are national numbers, so nothing to do with Hackensack having its own incidence. So this is what the benchmark is. So do we really see it that often when you're seeing the patients here at Hackensack? Honest answer. It doesn't have to be okay. And that's the reality. And this percentages, even in the national numbers, is through mixed data. So looking at all these other diagnoses, or sitter usage, or restraint use, or the other markers that point towards delirium. So we as clinicians do a lousy job in diagnosing delirium. So I think our number one challenge here is to make sure that this makes it to our problem list. So all of your mental status changes, please make sure that you pick either delirium as or toxic metabolic encephalopathy as your problem list, so that we can act first we can address the problem, the severity of the problem correctly, and then we can figure out what we want to do about it. Correct. Okay, so that's the connection is so important, and that's the reason why it is so complicated. And unfortunately, the CMS has not helped us because the ICD-10 codes, delirium does not capture the severity of illness. So we are forced to use toxic metabolic encephalopathy as our ICU diagnosis because that captures the severity index for the hospital. But then in physician's mind, we don't necessarily put those two together, and we don't necessarily add all those nice intervention that we have available. So that's why it's important for all of us to remember that.
So patients develop like hospital acquired or ICU acquired during their stay versus the initial presentation.
Correct. Correct. So that's why 1/3 may come to us, but then the rest 2/3 is happening while they're with us. And we're going to talk a little bit about what we do to them to make them delirious. And so every time you're seeing a patient, keep that in mind, that this is the damage that I am doing to my patient. And I better be sure that I need to do this if they're going to end up with this prognosis. And this is the reason why we care about delirium. So if it takes two patients, same age group, same sex, same comorbidity, same admitting diagnosis, if one develops delirium versus the other, the patient who develops delirium has 10-fold increased chance of dying in that particular hospitalization. So it's probably one of the most poor prognostic factors for your admitted patient. And this is the reason why we need to care and identify and treat this group special, okay? They are the ones who are going to have increased risk of nosocomial complications. They are the ones who are not going to be able to discharge soon enough. They are the ones that are going to end up in nursing homes because of the poor functional recovery. And unfortunately, that increased death risk goes to their patients up to 2 years from that incidence. And the longer they stay delirious, of course, the worse is the prognosis. Okay. So let's talk about how expensive is delirium. So we talked about the mortality, but here's the expense. So $143 to $152 billion annually are spent on this particular disease, which translates into around $16,000 to $65,000 per patient. And look at the costs attached to some of the other common chronic diseases that we deal with on a day-to-day basis, and see the difference between, so see how expensive it is. So not only it is a poor prognostic and high mortality, but it's also very, very expensive disease. So whatever we can do to minimize the cost, the better it is for our healthcare system as well. So the reason why delirium becomes so tricky is because it's not one thing that causes delirium. It's multifactorial. There's a lot going on. Just as we saw the patient that we have, she has hypertension, diabetes, CHF. So she already has 3 comorbidities. Now you've added that UTI. So that's the 4th factor. So there are a lot of different processes that happen simultaneously. So it could be the neurotransmitters. It could be the inflammatory process. It could be the blood-brain barrier permeability. It could be the oxidative metabolism. And majority of the times, a lot of these are acting against each other in that particular patient. It's never one particular pathway that's causing the delirium in that patient. Okay. So these are some of the best established factors is the decreased cholinergic activity. And that's the reason why our dementia patients have the highest risk of delirium. And that's why it's important for us to distinguish between dementia and delirium. And that's why we have the mini-cog and the CAM screening done on our patient population. Increased dopamine activity, dopamine measured in patients who are especially hyperactive delirious, tend to have higher levels, and that could explain why antipsychotics are one of the important treatments in treating hyperactive delirium. Okay? Low or excess serotonin, that could explain why sometimes when you're using psychotropic medication that could be associated with delirium, and similar with the GABA. So these are your classes of medication that you should be thinking about if a patient is coming in with acute mental status and if any of those medications were started. These are various forms. We do a good job in diagnosing our hyperactive or agitated delirium. Why is that?
Because they're disruptive.
They're disruptive. They interfere with our life. They interfere with nurse's life. We have to take care of that patient because now we can't take care of anybody else. That's why we diagnose hyperactive delirium much better than our hypoactive delirium, which is a perfect patient. Patient is in bed, knocked out, nobody has to worry about it. But unfortunately, that is equally dangerous as your hyperactive agitated patient. So we have to make sure that we diagnose both categories. And then of course, mixed way, they go back and forth between hyperactive and hypoactive delirium. And most of us have heard the terminology sundowning, where you're going to see more agitation or hyperactive delirium in the later part of the day. And that's the reason why it's called sundowning, because you will see that with, and you may not necessarily see in the evenings in the hospital setting. It all depends on what exposure of light your patient is getting. So if they are in a dark corner, the sundowning can happen any time of the day. And that's why one of the things that we like to do is get these high-risk patients to the window bed rather than the other bed, so we can try to keep the diurnal variations to the minimum. Okay. So we talked a little bit about the underdiagnosis. As you can see, unfortunately, I prepared these slides, this particular slide 5 years ago. We haven't made any dent into that 20% to date. So we have a long road. Okay. So this is CAM. Have you guys looked at CAM in our EPIC? If not, I would encourage all of you to do it today in the flow sheet. And also look at the drop downs for each of the questions, so it helps you understand how easy we have made it for our nurses to administer this tool. So it's more than 95% sensitivity and specificity, and this is what we're looking at. So we need the first two, the acute change in mental status and the inattention. So we definitely need those two factors, and then either disorganized thinking or the altered level of consciousness. So each one of these questions in EPIC is attached with drop down what it means. So it's easier for the nurses to administer. And in majority of the times when I see inaccurate CAM, it's the first question that a lot of people struggle with, is defining that acute. What does that acute mean? Okay. So this is what it looks like in Hackensack. Okay. And it also, on the same screen, you're also going to get your falls screening. So you can look at that data as well. But again, very easy. Tells you, and the system calculates the absent or positive automatically. So you just have to, even if you don't want to look at any other other rows, at least look at the interpretation of the results, and it will tell you what you have to look for. So even if you're in a rush, there's no reason for you not to look at this data. Okay. DSM-5 has its more extended version of the same criteria. We don't like to use it because it's cumbersome. We want it to be as practical as possible since we're going to be dealing with this on a day-to-day basis. But again, it is available for your reading. Okay. I'm not going to go over each of these questions. I think all of us can read this. This is self-explanatory. I just put that information in there, but take a look if you need to, or you should be looking at it to understand the questions a little bit better. It also gives you examples of how you'll check for disorganized thinking. And that's it. Okay, so these are some of the risk factors that when you're admitting a patient, you're going to start thinking about delirium if you see any of these risk factors. So advanced age itself is a risk factor. Any history of dementia, any history of stroke, any history of Parkinson's, so neurodegenerative processes, you're going to put at high risk of delirium. Any functional impairment. So again, this is where your the false risk assessment would help you to understand the functional impairment. So the more medical comorbidities, the higher the risk of delirium. Any history of any, not just alcohol, but any other abuse. So smoking, alcohol, any other types of drug abuse is a risk factor. And the reason you especially want to know about smoking and alcohol, especially that if your patient is going to be in the hospital for more than 24 hours, you got to start to worry about withdrawal. And if you don't anticipate that, you are going to cause delirium. So those are one of the reasons. Unfortunately, male patients are more at risk of getting delirium. We don't know exactly why. And any sensory impairment. So again, going back to our nursing assessment, our nurses here at Hackensack also assess for hearing, and they're supposed to provide your patients with hearing amplifiers if they have hearing impairment. So there's a drop-down menu which allows them to order. So again, look at that. Make sure that your patients are getting those hearing amplifiers if they have hearing impairment. And now, my least favorite thing to talk about is what do we do to our patients to cause delirium. So restraints is a major risk factor. And when we talk about restraints, the mittens that we use are considered as part of restraint. So please don't think as your hand mittens as a benign form of restraint. It does put your patient at increased risk of delirium. Okay. Medications. What do we think is the number of medications that we have to add, any new medication that we have to add to put our patients at increased risk of delirium? I'm sorry. That's being a little bit too cautious, but I'll take one. That would be all of our patients then, right? So I'm talking about any new medication that we're adding just for this admission. Is there? So 3 is the magic number, so 3 or more, and that includes your Tylenol and Lovenox. So how many of our patients that we have done admission and have not added more than 3 new medications, no matter what the diagnosis is? That's pretty much everybody, right? So pain control is another important thing. Catheters, any form, are increased risk of delirium. Okay. Restraints, so again, thinking about oxygen tubing, your telemonitors, your IV lines, these are all restraints. So if your patients don't need it, please don't use it. If they're eating, drinking, they don't need the IV fluids. And of course, the environmental factors being in the hospital, the noise, the lights, the disturbance of sleep, the 2 a.m. vitals, the 5 a.m. blood draw, all of that is the perfect recipe to cause delirium. So do we think we do this to every single patient that comes to the hospital? Pretty much, right? I don't think there's any hospital that does not do all of these to every single patient of theirs. It's just part of what we do, but then I think this is the reason why we have to be sensitive towards it. Do we really need it? How long do we need it? And what can we do to minimize the exposure? How many of you have ordered amplifiers for your patients? Okay, we have one hand. Okay, so they're readily available. They're great. They make your life easier because your patient now can actually understand what you're saying. Please order them. And your patients get to take it home because these are personal use. So it's a great intervention that's going to go with your patient and help them even out of the hospital. Yeah.
Amplifiers, those aren't hearing aids, or what is it?
Those are not hearing aids. They're very crude form of hearing improvement. So they're literally amplifiers. So they just amplify so there are speaker phones and you speak in the mic and it amplifies them. And what else it does, because you're using it as a headphone, it blocks the background noise, which is one of the important factors in presbycusis. The background noise causes more muffling in the speech interpretation. So the combination of those helps improve hearing better. So it's not going to be as great as your hearing aids, but it's going to be better than not having any hearing at all. And a lot of times patients prefer this because it's so easy to use. They don't have to worry about the mechanism. It's simple headphones and you talk in the mic. So of course, tipping the scale is the higher the comorbidities, the sicker the patient, they increase the chance of delirium. Okay. And that would apply to, again, most of our patients, because with our new healthcare system, we're not really admitting patients who are not sick enough. So if they're admitted to the hospital, they're sick enough. If they're more than 65, all of these factors apply to them. Okay. So these are some of the precipitating events, and that's what we went through with our patient that we want to rule out. Is there acute cardiac event going on? Is this pulmonary? Is this sepsis? Is it withdrawal? And then going through the list as we manage to get negative answers to some of them. Okay. So what classes of medications are we thinking when we want to consider medication as a possible cause of change in mental status or delirium? So psychotropics, hypnotics, anticholinergics. Can you give me an example of common anticholinergics? Benadryl. Okay. How many of us thought Benadryl as an anticholinergic when we were ordering it? Okay. Okay. So please, it's very significant anticholinergic property. What else? Okay, let's look at our next slide and see if we missed anything. Okay, so yes, you use psychotropics and sedative hypnotics, but the reason why I put antibiotics and H2 blockers as red is that we never ever think of those as possible culprits. So please don't add those Pepcid orders if your patients are eating, drinking, and do not have any. We have come a long way from doing just the routine prophylaxis for GI, right? We know that we don't really need to do that. And antibiotics, especially quinolones, have increased chances of delirium. So is your Zosyn. And the reason I'm putting those two out there is because we use them quite often in our hospital setting. So almost anything and everything can cause delirium, and of course some are going to be more likely than the others, but do keep them in mind. I have seen enough people with antibiotics as well as prednisone being the causative factor. So your COPDers, elderly COPDers, keep that in mind. And a lot of times you may have to use it if they're in severe wheezing and you need to use the steroids, but at least now you can have that conversation with the patient and the family that this is what is happening. So it's not unknown. It's not scary. They understand what's going on. And then also for you to try to start the taper sooner than later. Okay. These are some of the other medications that we use often. Please, please, please do not use muscle relaxants in elderly. They are going to cause delirium. Okay? It's almost guaranteed. So please try not to use those medications frequently. Just because somebody's complaining of back pain or some spasm, please don't put Flexeril as your first order. You have access to the Beers criteria from your EPIC link. And the reason why we have it here is so that because we don't remember all of them, there's a huge list, but at least try to remember the big categories of your Beers criteria. Does everybody know what Beers criteria is? Okay. Somebody want to tell me what Beers criteria is? What's Beers? That is correct. And it gets updated every single year, and we add more and more to it. So just to make it, so it is a very long list, and that's why I use it quite often to just when I have a consult, but I'm not sure if this medication is causing it, it is good to check across Beers list. So I like using this mnemonic because it's easy to remember. It is delirium. And then it kind of gives you all the categories that you should be looking at. And you can see that drugs have definitely made it to the top of the list. So it's either because of drug or lack of drug, both of them. Electrolyte abnormalities we talked about, infection we talked about. It's a quick cheat sheet for you to look at when you're dealing with a patient with acute change in mental status, right? Okay. We talked about evaluation. We definitely want to look at those over-the-counter. You'll be surprised how many of people take Tylenol PM or Advil PM as their routine medication for sleep, or they're taking something for cold and sinus and not realizing that it has Benadryl in it. These are some of the cognitive symptoms that you will see that should make you think about possible delirium. So inattention we talked about. Acute memory impairment is more common as a delirium rather than dementia, and we're going to look at the next slide, which does distinguish between delirium and dementia. And some of the psychiatric symptoms, hallucinations, paranoia, if they're happening acutely, more than likely you're dealing with delirium than dementia. Okay. These are the physical signs. You see that quite often, and once you start looking for it, you will see how often you see the myoclonic jerks in your patient with delirium, and you will see that both in hypo and hyperactive delirium. So it's a good tool for you to remind if you haven't thought about delirium in that patient. If you start seeing myoclonus, you are dealing with delirium. Asterixis, we're all aware for our hepatic encephalopathy patients. Some of the other factors like psychomotor agitation, sleep-wake reversal, emotional ability, hypersensitivity to light and sounds. But again, those hypoactive patients are much more common.
How do you differentiate between a hyperactive and hyperactive? Like, what is the cutoff that you would put in for patients being normal or hyperactive?
So hypoactive, the hallmark is going to be lethargy. Okay, so depending on the level of consciousness, you're going to decide if it's going into hypoactive delirium. So if it's a normal consciousness, it's a normal patient, but any other variations of lethargy, it's going to be hypoactive delirium, as opposed to hyperactive is normal and above. Okay. So the workup is really a good history and a good physical examination. And then depending on what you find in your physical examination, the tailored or targeted labs. Okay? Not every single patient with acute mental status change needs a CAT scan, please. You're just adding one more test where the patient has to travel to a different environment, see more people, get into a claustrophobic dark room. You're just increasing the severity of delirium in your patient. So please try not to get CAT scan on every single mental status change unless you are seeing some focal signs. Okay. Have we done EEG and lumbar chap on our patients with with delirium? Yes, absolutely. Absolutely. So when needed, when warranted, these are good tools. But remember, that's probably 1 to 2% of your delirium patients. That's not 10% of your delirium patients. So use it judicially, but have that as a tool, but don't apply to every single patient. Okay. So this is what your differential diagnosis would look like, right? Dementia would be the big one. But then you also want to worry about, is it depression, is it psychotic illness, or is it just plain delirium? And this is how you would differentiate between delirium and dementia. So acute that onset is so important. So anything that's cognitive but it's acute, you're dealing with delirium, not dementia. Something that's slowly progressive, you're dealing with dementia. Okay, delirium fluctuates, dementia is progressive. Period. There's no fluctuating course in dementia. Okay, again, the duration. The, no matter what type of dementia you're dealing with, you're still looking at months. You're not looking at days or weeks. If you're talking about days and weeks, you're dealing with delirium. Again, dementia doesn't affect consciousness. If you're altered level of consciousness, it's delirium. So that's how you're going to distinguish between the baseline dementia with superimposed delirium when you start getting altered consciousness. Attention, again, is not impaired in your dementia patients until they're able to participate in conversation. So that also helps us tease out delirium versus dementia. And the psychomotor changes, which are, again, not a common feature for your dementia patients. Okay. As opposed to psychiatric disorders, similar factors. The psychiatric disorders are not going to cause change in level of consciousness unless it's medication induced, which again goes in category of delirium and not the psychotic illness itself. Disorientation is not, again, part of psychiatric illness. It's more seen with delirium. Same thing with acuity. Age is another important differentiating factor for psychiatric illnesses. You're not going to have an 85-year-old with the first episode of psychotic illness. It just doesn't happen. So if there's no history of psychiatric illnesses in the past, more than likely you're dealing with delirium. And then looking at the other risk factors. What can happen to our patients? We have established that it is an abrupt onset. We have established that it is acute. We've established it is fluctuating. We have figured out that it may last from few days to a few weeks. So this is what can happen to our patients. If we do everything right, if we don't send them to those CAT scans, we don't add those medications, we find out what's causing the delirium, your patients will have full recovery. Okay? If we don't do any of the above, you're going to have patients with longer delirium, increased morbidity, mortality, and increased risk of death. So this is the reason why first we need to diagnose delirium, but then more importantly, we also need to understand that that's not the primary disease. That's a projection of something else going underlying, and unless we find what is the underlying cause, you're not going to be able to treat the delirium appropriately. It's definitely not inevitable, right? We saw there are a lot of things that are happening that are done by the environment, not by the patient characteristic itself. So if we can modify that, we can modify delirium. So it's not inevitable. It happens often, but it's not inevitable. Okay? We do want to recognize it timely. We want to work on removing or reducing the causes. Of course, we want to do appropriate treatment, but more importantly, we want to target or focus our care on prevention and risk modification, which is what we're doing here with that delirium prevention bundle. So we have created a risk stratification score for our nurses, and it goes into green, yellow, and red. And each zone has different modifications attached to it, hoping to be more proactive in providing the right care to this patient population. Okay. So we've tick marked most of them. We're screening all our high-risk patients. We have a pharmacy committee here at Hackensack who looks at all the high-risk medication usage. We get that data on a monthly basis. We all look at it real time, and we intervene real time. So I get all the emails and calls about inappropriate medication use, and then we intervene appropriately. So please don't order those medications. You will get a call back from me. And then we'll have a conversation about why that medication was not appropriate. So we're really trying to be proactive in managing our patients and avoiding high-risk medication use in this population. We have taken measures to the extent that we have reported certain frequent offenders to Department of Medicine, and we have created a disciplinary action for those patients. So we take it very seriously. It's not, because again, these are the things that we do to our patients. And there's definitely ways to deal with this proactively with them after putting in the intervention. Restraints are the common restraints are again aggressively monitored by nursing as well as APNs to minimize the use. And we do multiple education sessions talking about the other types of restraints that we want to minimize the use. We know that there's a Foley initiative. We know there's out of bed initiative. All of these factors would help us take better care of our patients. We do encourage families and friends to spend more time when they're here, especially for our high-risk categories. We talked about hearing. There is a no noise or low quiet zone time frames that happen on the floors. So from 9 p.m. onwards, all the lights are dimmed to create that environment for the patients. Similarly, certain the quiet times, the level of noise is tried to be reduced as much as possible. We have a alcohol withdrawal committee, which is working on the processes to address these individuals appropriately and timely and proactively. Okay. So it is a multi-targeted strategy. We do need all of us to take care of these patients. So it's not just our job or just the nursing job. And all of us have to remember that it is multifactorial. These are, again, talking a little bit more about these factors. How can each one of this be addressed on an individual basis? And it basically gives you some guidelines about all these risk factors. So please look at it. Okay. So talking about behavior, how do we manage those hyperactive patients? Those are agitated, pulling things, getting the calls at 2 a.m. So again, these individuals, families are going to play an important role, encouraging them to stay with the patients. Even calling itself is helpful, and minimizing our physical restraint use or medication use would be helpful. Okay, so we do not do this at Hackensack. Okay, so please, please, please don't order restraints on your patients. Okay, we talked about this a lot. Okay. So there are activity cards on Fort St. John, which is what we are piloting, which would provide some of these activities to our patients who would address the glasses and the hearing piece and mobilization piece. These cards would also offer snacks to the patients to help with the hydration and the nutrition piece. And we have put out education material for the patients and the families on these floors. So please use them to educate your patients and your families. So this is what happens in our Hackensack patient's life, okay? So we as physicians are obviously involved, but our case management is involved, our nurses, physical therapy, and all of these work together in those patient rounds to create these processes. So CAM and Minicog we talked about. We have the early morning Rise and Shine program. We have the out of bed program within 24 hours of admission. We talked about polypharmacy. Physical therapy is actively involved in mobilizing all our patients. We talked about education, and then transition of care, working together as a team to make sure that we have the right transition set up for these patients. So we do have a multidisciplinary team approach, and hopefully that helps us to provide better care. So if we absolutely had to use medications for all those calls of the punching patient, pulling patient, throwing tantrums patient, what is our drug of choice? Okay, so haloperidol would be the choice. The reason being, we saw that dopamine has some role to play in delirium in delirium onset. So that's probably the reason why antipsychotics work the best in this population. So please use antipsychotics. Please do not use benzodiazepines in managing these patients' behavior symptoms. You're just worsening the delirium. And please, please, please use the smallest possible dose. We talked about it this morning. 0.5 is your starting dose. Not 1, not 2, and definitely not 5 milligrams, which a lot of our colleagues are used to ordering. So please, please order the baby dose. You can always repeat it in 15 to 20 minutes if you need more. And that's always the right thing. If you're going to use IM or IV, make sure you looked at the QTC. If you're going to use IV, make sure your patient is on telemonitor. Please do not give IV without a telemonitor. If your patient goes in torsades or any other arrhythmias, that's a big medical legal liability. You can use for urgent processes, you can use IM if there's no telemonitor available. What is your QTC that you start worrying about if you're considering using antipsychotics? Okay, so 500 is absolutely no. If it's 500, you're not going to use. Okay, where do you start getting worried? Okay, so females and males are different, so you want to look at those differently. We didn't talk about it a little bit this morning, but females anything more than 450, you want to start worrying. Males anything more than 470, you want to start worrying. So you want to be cautious and monitor them closely if your QTCs are in that range. But yes, 500, if your patient doesn't have a pacemaker, they're not going to use antipsychotics. If they have pacemaker, it's okay to use for urgent issues, but again for short term, not as a long term. The only time you're going to use benzodiazepines is if they're going through alcohol withdrawal or if they're going through benzodiazepine withdrawal. And you're going to get, if there's no EKG and you're using the antipsychotics, especially haloperidol, you're going to get the EKG to look at that QTC. No reason for you not to order that EKG. Okay. We talked about most of these, so I'm not going to repeat, but this information is going to be available for you to go back. So it lists all the program that we have here at Hackensack. These are the medications that we're targeting at Hackensack that I get the log if any of these medications are ordered is the Benadryl, lorazepam, zolpidem, diazepam, and haloperidol. The reason why we monitor haloperidol is because, again, our first line of treatment is non-pharmacological. So if we're using pharmacological treatments, we want to make sure that they're used appropriately and with the appropriate dosage. So just because haloperidol is allowed to use in delirium management doesn't mean you should be ordering this as a PRN standing order, or it should be just used on any and every patient. So we do look at the use and we want to make sure that it is used appropriately. Okay. You can call the rapid response if you are concerned and if you're not able to get to your patient, because any patient you get a call about altered mental status change, you better be going down and seeing that patient. You don't want to address these patients on the phone. And if you're not, and if you're concerned, you can definitely activate rapid response. As you are aware, pharmacy does look at medication reconciliation. I'll be happy to share the delirium checklist that I've created for geriatrics. And as we talked about, we do look at all this data in our geriatrics quality council every other month. Okay, we celebrated our Delirium Awareness Day. This year was March 13th, and we will be continuing to do that to again increase awareness for all of us. So delirium is dangerous and is expensive. There are things we can do to prevent it, and there are definitely things that we can do to treat it appropriately. So we all have to work together as a team to make it happen. Okay, hospital is a maze, right? We all have seen hospital environment one way or the other, especially when you're in a new environment. I'm sure right now all the interns can relate this maze diagram for Hackensack. You can easily get lost. So please be mindful that your patient is in the same environment. They're here for the first time. Please try to help them as much as you can. This is what I used to prepare this. Any questions? Yeah.
So let's say we have a patient who's very delirious,
Mhm.
altered, and redirection is not working,
Mhm.
and there's a lot of people in the room, can't calm them down enough. We have to give them some data.
Mhm.
QTC is prolonged.
Mhm.
What would you recommend?
Okay. So in that situation, very low dosages of benzodiazepines may be required. But then you're going to make your due diligence to write down why you're using that benzodiazepine. Okay. And anytime you're using psychotropic medications to control behavior, please make sure you're talking to the families, that you've discussed the side effects, that you've discussed why it is being used. It is important for the families to understand why we're using these high-risk medications. You can also use Depakote if the patient is not significantly agitated. If they're taking oral medications, valproic acid is something else you may consider using.
So we have a patient who's extremely delirious, 4th day of hospital admission, refractory to all, like orientation doesn't help, restraints don't help, refractory to Haldol, given multiple times. What would you recommend?
So this would be a great patient to call geriatrics or psychiatry as a consult.
And psychiatry is already been called.
So I would recommend geriatrics to be involved in that care. And I was going to also put out that as a resource available. You don't have to wait for day 4 to call us to help you understand this patient
But
better.
this is like an overnight thing. You know, there's a patient very agitated. This is the 4th day of delirium, right? And I've already given Haldol to maybe like 2 or 3 multiple, 3 times total, 3 milligrams total of Haldol overnight.
So
And psychiatry isn't coming yet, and Jerry's not there.
So again, I think this is the reason why the proactive approach is important, that we want to identify this high-risk population and get geriatrics or psychiatry involved earlier on so that it's not that 2 a.m. crisis, because there's very little that you can do at 2 a.m. because we don't have all the members available to take care of. So this would be a classic patient to have geriatrics involved to figure out what's going on, how can we help this patient better. So please remember, we are available. Even if you didn't want to call an official consult, you wanted to just discuss something, you wanted to have an educational conversation, feel free to call us. We're always available. You guys are all going to come and rotate in geriatrics with us, but we don't want to keep this experience only as your 1-month geriatric rotation, because you're going to take care of your geriatric patients every single day. So feel free to use geriatric service as your resource, and reach out, and we're always happy to have conversations and help out. Okay, any other questions? I'm surprised I didn't get a question about sleep. Okay, what are you guys ordering when I called you and I'm 75 and I'm not able to sleep? Okay. So no Benadryl, important message, absolutely no Benadryl. Okay, so we can use low-dose trazodone. We can use what? Thank you. So that's where you want to start. You want to start with your chamomile tea, or you want to start with your warm milk with honey, which is available on the floors. Your nurses can request it for your patients. So don't take it lightly, and don't think that as not an intervention. That is an intervention. So you want to start there. And if those things are not working, you can use low-dose trazodone. You can use low-dose mirtazapine. You, of course, can use low-dose zolpidem as a one-time use if absolutely necessary, or if your patient were using zolpidem at home. Those would be the only 2 criteria. But again, use 5 milligrams. You don't want to use 10 milligrams in your patient 65 and older. So keep that in mind. Okay. Oh, so we passed 1 o'clock. I didn't realize.
What was the name of the medication that causes delirium?